Welcome to the Birmingham Medical News Ask the Doctor podcast. To get started, I'm Steve Spencer. I'm the founder of the Birmingham Medical News, and we do this podcast in partnership with Kassouf & Company. Kassouf is an accounting firm in Birmingham that has been in business almost 100 years. They focus on all areas of accounting, from accounting for small, large business individuals, as well as wealth management and advisory services. And for our purposes, they have a healthcare advisory group that's been around a long time, one of the better advisory healthcare groups in Alabama. So we thank Kassouf. Our sponsor today is a company called Kerecis. Now, the Kerecis story is pretty interesting. It goes back 20 years, started with an entrepreneur in Iceland named Fertram Sigurjónsson. Sigurjónsson, back around 2006, was working with a biomedical company, and he was struck by how many diabetics lose limbs to wounds that won't heal. In fact, the number is close to 500,000 a year. So, at that same time, biologics were emerging to use as skin grafts for wounds. And most biologics then, as well as now, actually come from pig skin, some from cadavers, things like that. So Sigurjónsson looked around and he wondered what they might have in Iceland to work with. And he realized, what's Iceland full of? Fish, specifically cod. Found out that fish skin is basically identical to human skin. The epidermis, the dermis, the subcutaneous tissue, it's identical to human skin. This is important, and I'll tell you why. When a skin graft is made from pig skin, because viruses and disease can be transmitted from pigs to human, that graft has to go through a really intense processing procedure that degrades it somewhat. There's no known transmission of disease from fish to humans, so it means a lighter processing, which preserves its structure, and it makes it a more intact product. Now, in researching this, I found a number of circumstances of patients who had wounds that hadn't healed for months, and one guy up to a year, and they used the Kerecis fish skin graft, and the healing started within weeks. It's been a really good product. It was approved by FDA in 2014. It's approved by Medicare, most insurances. So I would say if you're a doctor, a nurse, or a therapist of any type who deals with wounds, I would definitely look into it. It's Kerecis.com, just simply KERECIS.com. All right, so our guest is Dr. Blake Phillips. Dr. Phillips got his medical degree from University of Texas at Houston. Then he did his internship and fellowship at UAB here in Birmingham. And he's been practicing. He is a dermatologic surgeon. Am I correct?
Correct.
And he's been practicing with Total Dermatology here in Birmingham. Mm-hmm. So today we're going to focus on skin cancer. And I guess, Dr. Phillips, tell me about the process of, what are the dangers of skin cancer? What's the process by, what does somebody need to look for?
Sure. Yeah. So skin cancer is incredibly common. The most common type of skin cancer there is, the most common type of cancer in general right now. So rates only on the rise, unfortunately. But there's multiple different subtypes, and skin cancer is kind of an umbrella term. It includes everything from, the small, tiny structures that lead to rare forms in the skin to just the more common and lower risk versions. So it ranges from things that are relatively aggressive to things that are generally fairly slow growing and are more locally destructive and locally invasive. So by and large, what you look for really depends upon the subtype. So I would say starting with the most common three, that's going to be basal cell, squamous cell, and melanoma.
Okay.
Basal cell and squamous cell generally come from the types of cells that make up the structure of the skin, and those tend to grow like more mass or we call a neoplasm-like growth of a little tumor. Sometimes it can look like a non-healing sore or a bump or a blemish or pimple or something that's growing and not going away. Sometimes they can have bleeding. Sometimes they can be a little bit tender. Sometimes they're just itchy. But if you're getting new lesions that are persisting and not going away, that are growing, it's worth at least getting something checked out. Melanoma, by contrast, is most typically going to be picked up in a stage where it is relatively flat and a discolored lesion. So it tends to be more pigmented. It comes from the cells, melanocytes that actually produce pigment. And so most of those lesions tend to be, brown or have multiple colors, sometimes brown and black and red. And generally, the rule of thumb is we use the ABCDs as a sign for melanoma. So A is for asymmetry, B is for borders or having border irregularity. So something that rather than having a nice sharp edge looks like it's a little bit moth-eaten or irregular. C is for color, so either very, very dark, out of proportion to someone's typical moles, or multiple colors in one lesion. D is for diameter, which is not an entirely specific indicator, but generally larger than a pencil eraser or something, and or E would be for evolution, which means it's changing or growing. And so if you've got something that was relatively small and then is now rapidly changing and growing, those are worth getting checked out. That doesn't mean that everything that meets that criteria is going to be cancerous, but it's at least worth familiarizing yourself with those risk factors. Or I should say those warning signs. Risk factors, more specifically, are going to be history of extensive sun exposure. So the vast majority of skin cancers come from ultraviolet radiation, although there are some other subtypes clearly that come from other sources. But most folks encounter skin cancer because of either ultraviolet radiation from the sun or occupational exposure to radiation or tanning bed use and things like that. So protecting yourself from the sun is the most common and simple and inexpensive thing you can do. Cover up, wear sun protective attire and brimmed hats and sleeves whenever you can. Avoid peak UV intensity hours in the middle of the day. So that kind of 10 a.m. to like 4 or 5 p.m. window where the sun is hottest. And then just being aware of the amount of ambient UV exposure you're getting day to day. So
it's you said the most prevalent cancer
in general, yeah, overall. Now that it's not reported along the same lines as a lot of the other forms of cancer, because the more prevalent subtypes are not widely metastatic. So basal cell, which is the most common subtype of skin cancer, has a lower overall risk profile than, say, most of the cancers that are commonly tracked and discussed. So
do you see very often people who come in when it's really late? I mean, they haven't paid attention.
Unfortunately, yes. I think in Alabama you find all manner of folks that come from different walks, and some people it's not about finances and access to care and means, but others it is. And so there's an element of sometimes people that lack access to care and or are nervous about the financial implications of accessing care that will come in a delay. Oftentimes also you just have somebody that thinks it's something else.
Yeah.
Expected to go away. So,
right.
But, how aggressively those behave really depends on the subtype of the cancer and the host factors or the individual patient's health status and things like that.
If somebody comes in really late, I mean, is it? I don't even know the cure rate. Is it relative?
It varies. So, it would depend on the type of cancer. Sure. So, again, basal cell being the most common one. If it comes in late, it's a very locally destructive type of thing. Meaning that you're going to have not only a big wound that's non-healing and tissue that's being lost, but you can actually have real functional compromise in things. It's very rarely metastatic though. So most of the time you have to willfully neglect it for a while before it's going to spread anywhere else. And even at that, it's not highly common versus squamous cell, which actually causes more deaths than melanoma.
Oh, okay.
But the rate is lower because in general it's not quite as aggressive per unit cancer, but it is more prone to metastasis and local recurrence and things like that.
Okay.
And melanoma clearly, I think, is widely advertised as one that can misbehave pretty quickly.
Yeah, that's the only one I was actually familiar with. So
There's a whole laundry list of other things that are rare and awful and scary, but they're probably beyond the scope of the talk.
okay. And I know you specialize in surgery. I believe you call it micrographic surgery.
Mohs micrographic surgery is the common name for that. So.
Okay, can you tell us first, from the beginning, if you would, like when a patient comes in, what is that? Is this surgery for all types of skin cancers, or only for certain? And also, what's the sort of dividing line between a patient who doesn't need that surgery and a patient who does?
That's a great question, actually.
Okay.
So I guess I'll back up and just talk about the thought process that goes into directing different treatments for skin cancers. And the first is, the subtype of cancer you've got. Mm-hmm. So you have the main overarching, subtype. Let's say it's squamous cell. That's a relatively broad umbrella term. Mm-hmm. And there are different nuances within squamous cell when you look at a pathology report. Generally, a patient that's going to be seeing me has already had a biopsy of the lesion. Mm-hmm. So they've seen likely either a primary care doctor, a dermatologist, ophthalmologist, what have you. Mm-hmm. And there's been a biopsy performed and it's shown that it's a skin cancer and they've referred them for treatment. Mm-hmm. And oftentimes they treat those things themselves in-house when it's indicated because it's a relatively low-risk lesion that doesn't require something more.
When say in-house, you mean a primary care doctor?
Depending upon where you are. Most commonly, it's going to be, dermatology numbers, but I mean, many places in the state, particularly in areas where access to care isn't quite as good, and there are a lot of primary care doctors that are doing wonderful things. So, so there would be a biopsy performed, and then based on what's in the pathology report, you would look for things like high-risk features, infiltrative growth patterns, poor differentiation, spread around nerves and inside of lymphatic vessels and things like that. And then based on that, you choose an acceptable amount of preoperative investigation, and then treatment plan.
Okay.
So when someone is sent for Mohs surgery specifically, it tends to be reserved for areas that are either cosmetically or functionally sensitive and or just tissue limited. So vast majority of what I do would be probably on the neck and above. So a lot of head and neck related sites, but also hands and feet, genitalia, lower legs, ankles, and places you just don't have a lot of tissue to give up.
Okay.
And then the secondary indication there would be a very high risk cancer. So something that has features that might make the likelihood of positive margins on a traditional, excision, which is just cutting out a cancer, more likely to be positive or to have higher rates of local recurrence. The unique thing about Mohs surgery is the process by which the tissue is examined to look for residual cancer cells extending outward or underneath the lesion itself.
Well, one quick question, and maybe this is kind of what you're saying. I'm curious as to how Mohs differs from just a normal incision. Is this what?
Sure. Yeah. I mean, I'll try to.
I didn't know if that's what you were.
Generally getting at that.
Okay.
But I would say. Simplest terms, most of the time something is cut out that's not, doesn't require Mohs, then it would be treated with something called a wide local excision if you were going to excise it. And there are other treatment modalities that they're oftentimes very much appropriate. But generally you would have a lesion, and that lesion would be removed with a protective ring of intact, normal appearing skin around the outside.
That's a regular incision, right?
Regular excisions. Okay. Regular excision, you've got a lesion that you can see, and then you would measure a ring of skin around the outside of that, generally based upon treatment guidelines with some cancer care guidelines through the NCCN is the one that most people would use.
Okay.
And so hypothetically, let's say you were taking a 5 millimeter margin around something, you would measure 5 millimeters in a circle all the way around, and then cut that out and send it to pathology. And pathology takes that tissue and they process that like a loaf of bread. And so they're going to slice through that lengthwise and get transverse sections looking through that and take a look at that vertical cross section and look in serial sections and see if all the edges appear to be clear around the outside of the tumor.
Okay.
And for most, assuming that the appropriate margin was taken and it's a low risk cancer, that's a reliable thing to do.
Okay.
Where Mohs changes that is that rather than removing that and serially sectioning it vertically, we do it horizontally. So it's more of like, think about lifting up a Reese's peanut butter cup with the wrapper on. Okay. If you sat it down, you could roll that wrapper down flat and then look at the base of that wrapper underneath it, and that would give you a full representation of everything that was initially, touching the bottom of that Reese's peanut butter cup.
Okay.
Similarly, to bring that back to tissue, I would remove a lesion, and then it's laid down flat on its base and it's processed full face. So you're seeing the underside of that 100% of the contiguous margin in one field of view, which means you don't have the potential error of the gaps between those slices of bread that were being processed the more traditional way.
So if I understand you right, let me make sure I get this.
There, go for it.
So the difference in Mohs is, I hope I'm right, is not the incision, but rather the, I guess, I don't know the right word for it, the study and the what you have after.
So she's like, there is the histologic technique is specific, that horizontal sectioning technique. There is some nuance to how that tissue is taken so that you can lay it down and process it that way. So yes, there is some difference.
Because you mentioned, and sorry, Grant, but you mentioned to me earlier that Mohs was very specific.
Yeah.
Okay. So it's a little bit different in this.
I mean, like with any type of kind of subspecialized procedure, there's going to be some nuance to how you do it. But the foundation of Mohs is that horizontal full face sectioning of tissue.
Okay.
Because you're getting 100% margin analysis in one plane of view. So you're actually just seeing a lot more of the actual margin tissue.
Okay.
Which enables you to bypass taking big margins. So ordinarily,
nice.
That's why it's useful for these areas that are fairly tissue limited or cosmetic or functional.
Yeah, totally.
Because now instead of us taking this big ring of tissue around the outside, you can
take a smaller
right at the edge.
I can totally understand when you said face and neck, of course. So
that means that the other nice thing about the way that modern Mohs surgery is done is it's long ago it was processed that way, but there was still a delay between the removal and the repair. So real kind of nice bit now is in the modern era with frozen sections, we take that tissue in real time and take it to a laboratory in the same space that we're in. You process that for about a half hour and come back and say, hey, it's all gone, or we need to get a little bit more, wherever this corresponds on a microscopic map that's made. And that means that you're going back and forth and removing very much precise and corresponding tissue, sparing extra removal, and you're able to clear that tissue in real time and repair them the same day. There's no wait and no turnaround.
Yeah, that's great.
It can be a long visit, but
it's better. Yeah, I mean, it may be, like you say, a long visit, but number one, that means they don't have to come back.
Right.
If they find they hadn't got it all.
Sure.
And yeah, that just sounds to me like it'd be much, much better.
Yeah, when indicated, it's fantastic. So high cure rates, small wounds is the ultimate goal.
Yeah. I'm almost surprised that everybody wouldn't do that.
Well, and again, there's, like with anything in medicine, there's a balance to be struck between, applying a technique when appropriate and overuse.
Okay.
And so there are some guidelines that we generally abide by that help to dictate kind of consensus guidelines, what is most appropriate for Mohs surgery versus what could be very reasonably approached and treated with our modality.
Yeah. Okay.
So we call that, very aptly the appropriate use criterion. And so that generally governs the way that I make clinical decisions. That's not gospel, but you use that as a good guideline and try to abide by that as much as possible.
Okay. Okay. Well, that's great. I understand. I knew just the name Mohs, but I did not know.
Yeah, it's out niche. That's what we talk. It's a niche, and there aren't many folks around, doing it. But more and more, it's becoming recognized.
And how long has Mohs been around?
It's a great question. I'm not sure that I have the specific dates, but it's been several decades. I know, in Birmingham, Dr. Monheit actually started the practice that I've
with your practice, right?
And he started out as the first Mohs doc here, and it's been roughly 30 years.
So it's been a while.
It's been a while.
Interesting. Was there anything else we should tell folks in terms of, just skin disease?
I think if you have no relevant history of skin cancer personally or in your family, and you're diligent about doing sun protection and things, I wouldn't lose a lot of sleep over every specific individual, mole or blemish or thing that you've got on you. But if you do have relevant risk factors, if you're a fair-skinned person that's had a history of a number of blistering sunburns, if you're a former tanning bed user or current, we would love for you not to be. But if you have some risk factors, lots of moles that are relatively atypical or dark, and or a strong family history of numerous, skin cancers, it's reasonable to have a good baseline screening with somebody.
Okay.
Find a reputable board-certified dermatologist and go and see them.
I actually did that with your practice. This goes back before COVID. No history of skin cancer in my family, but I always just thought, well, I better get my own circles looked at. The blue-eyed guy. Yeah. So I went to Total Dermatology for it.
Yeah. That's a good gang. There's several wonderful people there.
Yeah, definitely. Well, thanks a lot for coming. And I think that's some good information. I know I learned a little something.
Sure. Yeah, thanks for having me.
Yeah, all righty. Thank you for listening to today's episode of the Ask the Doctor podcast, brought to you by the Birmingham Medical News and Kassouf & Company. Please make sure to like and subscribe, and make sure to tune in for our next installment. I'm Steve Spencer, and wish you and your loved ones a healthy journey until we see each other again.